Diabetes mellitus. Acute manifestations. The three classic Ps are polydipsia, polyuria, and polyphagia. Other findings include weight loss, diabetic ketoacidosis in type 1 diabetes, and hyperosmolar hyperglycemic state in type 2 diabetes. Rarely, diabetes mellitus can be caused by unopposed secretion of growth hormone and epinephrine. It is also seen in patients on glucocorticoid therapy, known as steroid diabetes. Chronic complications. Non-enzymatic glycation. Small vessel disease, also called hyaline arteriolosclerosis, causes retinopathy, neuropathy, and nephropathy. Large vessel disease, caused by atherosclerosis, leads to coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Myocardial infarction is the most common cause of death in patients with diabetes mellitus. Osmotic damage. This occurs due to sorbitol accumulation in organs that contain aldose reductase and either low or absent sorbitol dehydrogenase. Complications include neuropathy, such as motor neuropathy, sensory neuropathy in a glove and stocking distribution, and autonomic degeneration, which can manifest as gastroesophageal reflux disease, gastroparesis, or diabetic diarrhea. Other complications include cataracts. Diagnosis. Hemoglobin A1C of greater than or equal to 6.5%. This reflects average blood glucose over the prior 3 months and is influenced by red blood cell turnover. Fasting plasma glucose greater than or equal to 126 milligrams per deciliter after fasting for more than 8 hours. 2-hour oral glucose tolerance test greater than or equal to 200 milligrams per deciliter, measured 2 hours after consumption of 75 grams of glucose in water. Random plasma glucose greater than or equal to 200 milligrams per deciliter in the presence of hyperglycemic symptoms. When there is decreased available insulin, several metabolic changes occur. First, lipolysis increases, which raises plasma free fatty acid levels. This leads to increased ketogenesis, ketonemia, and ketonuria. As a result, an anion gap metabolic acidosis develops. Patients may present with vomiting, hyperventilation, and Kussmaul respiration. Second, proteolysis increases, which causes loss of muscle mass and weight loss. Third, gluconeogenesis increases and glycogenolysis also increases. Along with decreased tissue glucose uptake, these processes lead to hyperglycemia and glycosuria. Hyperglycemia and glycosuria then cause osmotic diuresis, which results in the loss of water, sodium, and potassium. This leads to hypovolemia, which progresses to circulation failure and decreased tissue perfusion. At the same time, hyperglycemia increases plasma osmolality, which stimulates thirst.